Yeah, it's the awareness that if my anatomy drifts to the right on the screen,
right,
I am below my fulcrum. If my anatomy drifts to the left on the screen, I am above my fulcrum.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we'll speak with Mr. Ryan Ross about fluoroscopy in the field of radiology technologists as it relates to C-arm use in the OR and in general. Mr. Ross is originally from Scotland, hence why his accent is so incredible. He initially was a drummer. However, later on, as he describes in this episode, he found a keen interest in imaging, and particularly radiography. He attended Mercer County Community College, graduating with an Associate of Applied Science in Radiography in 2013. In 2015, he moved to Nashville and worked at Vanderbilt University in the Level 1 Trauma Center as a surgical radiology technologist. Mr. Ross eventually transitioned into education. He started as the clinical coordinator for South College of Radiography in Nashville in 2021 and is now the program director for the radiography program. One simply cannot stress enough how important fluoroscopy imaging is to the field of pain. We rely on it for most of our procedures. As such, we often depend on our radiology technologist expertise. In my conversations with Ryan, I was struck with the relative dearth of education for technologists when it comes to using C-arm and fluoroscopy in general. Mr. Ross not only has a podcast of his own, he also has a YouTube channel and has developed equipment known as the C-arm Training Phantom to help hone and educate technologists and fill this educational void. I'll make sure to link all of his affiliated websites in the show notes. As always, thank you so much for watching or listening. I hope you enjoyed this episode and learned something. Ryan, thanks so much for coming on the show. I really appreciate your time. Thanks for being here.
No problem, Dr. Davis. It was as soon as I saw you on the LinkedIn, I thought we need to talk because we just seem to be so in tune with how we view fluoroscopy and its importance. So it's great that we're able to connect this way.
Yeah, absolutely. So I am curious though, how did you get, you initially started as a drummer, correct?
Yes. My drums are just over my right side. You probably just can't, it's just out of frame, but yeah, I still have that. Yeah.
How did you get interested in radiology?
So I was a drummer for a good couple of decades and came over to America in 2008. My wife, she's a veterinarian, so she was studying at UNC, not UNC, North Carolina State, and University of North Carolina, but North Carolina State. And after that, we kind of bounced around America a little bit. We lived in New Jersey a couple of times. We lived in Arlington, Texas, and obviously North Carolina. And as a musician, every time you move, you lose some of your network. And we just got to a point where children was probably on the horizon. We thought, we have to start looking at something that's a little bit more consistent financially for me, and also something that would take up my day rather than just stay at home, waiting for the gigs in the evening. So we looked at local community colleges, and my wife was actually the one that said, maybe imaging would be good for you. She's like, you kind of have a kind of physicsy brain and you're good with spatial awareness. And we saw that radiography was on offer at a local community college. And she said, let's go ahead and submit an application and see how it goes. And I got waitlisted, but fortunately, unfortunate some circumstances for others led to me getting a position. And I just ran with it. It just really seemed to work well with me, my visualization. And I'm just that type of person that when I get involved, I become blinkered and I just get so focused. So as best as I can try and do something, that's going to be how I approach it. That was back in 2013. I graduated X-ray school.
Okay. And then, I mean, since that time, you've done quite a bit within the field, and you have this phantom training, not only the image training device, but also a manual to go along with it. And I feel like that's so impressive, especially, coming from a background where I don't get much, I guess, radiology exposure until I'm in my fellowship, frankly, a little bit in residency. Even for me, it's super helpful. And so I'm just curious, like, what prompted you to, first of all, make that? And then secondly, like, are you currently using it now? Are people, out there using it?
Yeah, thanks so much. So a kind of little background on that is I eventually ended up at Vanderbilt University Medical Center as a large level 1 trauma center. So I was hired as a surgical technologist or a surgical imaging technologist. And I gravitated towards the harder cases, which was your pelvis, acetabulum, etc. And I saw that there was a huge level of precision that had never been shown to me at any point through school. And there was the demands of the surgeons as well, because when you're working with such complex anatomy, the precision and permanent placement and, permanent fixation, hopefully, really requires on-point imaging. So that, again, through training, never had any indication. So really the surgeons kind of dragged me along, but also tying in with my mentality of I have to be the best, or I have to be the best that I can be, seemed to be a perfect match. And then once I left that field of imaging, I was promoted into quality compliance and eventually the manager of diagnostic imaging. But I still kept in close contact with the surgeons, the orthopedic team primarily. And we would always have these conversations about, we just don't get quality technologists coming through out of school. There just seems to be a huge lack in what the expectation is of this. We shouldn't have to wait 5 years for technologists to get their skill up. So I think, again, maybe just with the way my brain works, I kind of looked at what are the common challenges or common angulations in terms of views that technologists use. And I kind of married that with the idea of perfect circles, which when you're doing intermedullary nailings, it's a precision of the exit and the entrance holes on the rod, because for perfect alignment, you get this completely perfect circle. So that shows that your central ray is completely perpendicular to the anatomy. And clearly that's the goal, because now you have a non-distorted or non-divergent beam presenting that center of the image. So I doing SI screws where you always want to have this kind of pivot point of where both trajectories intersect, which would be the fulcrum. I termed this as the image fulcrum, but the fulcrum is a term that does actually exist. Again, lack of training. Yeah. I didn't know it existed, so it was kind of neat that I'd stumbled upon the correct terminology, because that would come back to tomography, the old tomographic series. If you're doing like IVPs where you keep the anatomy in the central field and then you can manipulate the tube over. So there's a similarity there, obviously, with back and forth projections for your inlet outlet when you're doing SI screws. And I had done a lecture for ASRT, the American Society of Radiology Technologists, discussing that the image fulcrum was a system to reduce patient dose and provide more consistent imaging and efficient imaging during these complex trauma cases. Because you can have a really complex pelvis case, which if the technologist isn't aware, the way that the physics of what we are taught doesn't really apply in the OR setting. We're taught to get the receptor closest to the field, minimize all the magnification, etc. But if you are going back and forth, you can't wait those 8 seconds for the receptor to drop, and then you take an image and all your angles are off, so now you have to refind your planes. So that kind of pivot point, or the fulcrum, kind of made me think, I could probably design something where I have the fulcrum in the centerpiece of this imaging block, and then look at all the procedures that are fairly common. So your inlet outlet, you have your teardrop view, your obturator outlet, iliac inlet. You have your obliques, your 15, 30, 45 degrees over and back. And you have then your laterals. So I was able to tinker with Tinkercad on 3D printing, and basically just started with a block of plastic and thought, okay, well, if my AP goes here, where does my lateral go? Okay, now I have those two. What about if I add my inlet? So because of my practical experience, I was able to visualize that into a solid object, which is now the Phantom. And I just started selling it earlier this year, and I have some schools using it, and they're finding some great success. It's really, even if you don't use ionizing in your lab, you can use the laser finder to highlight, because now if your laser travels directly through the Phantom, you are in perfect alignment. So you have a sense of positioning. And it's weird. I never even thought of that because I don't use lasers with my students.
And why is that? How come people, I mean, just as a tangent or as a side, why is it that I find that some technologists use lasers and some don't? Is it just purely a preference thing?
To me, that's their only source of guidance on accuracy. Because they're tracking that entrance point, and it gives them a sense of, okay, well, at least here is the center of my beam. So if you're trying to locate anatomy, obviously we don't know if we're centered until we take it.
Right, exactly.
But personally, I find the laser can be a little bit misleading. It's good for extremities that are constantly on the move, if your surgeon is manipulating. But if you have a fixed torso or something, there shouldn't be any need. Once you're in the field, nothing moves. So for me, it's really observe the image on the screen and then make all of your judgments from there, because that is your true perspective, is when you have the anatomy up on the screen. You can't see it any better. Right. Because if you're working with a laser, you're really looking at the surface entrance. So your anatomy of interest may be 3 inches more inward. So it works for some things, but really once you're in the field, I'm not going to use the laser because it can move as well. If it's not a locked in one, if you bump anything or your elbow rubs against it, it can turn. And again, when you're looking at that precision imaging from perfect circles or screw placement on SIs, 1 or 2 millimeters deviation on the near side ends up as 5-6 degrees on the other, and then all of a sudden you're nowhere near where you need to be. So I think people use laser as a kind of comfort blanket, and that probably becomes from, we have no training in our field that's formalized. I know we had briefly, that was our initial discussion, and that was all part of it. Is I think it's being able to separate yourself from the stress of the situation or surgery, to be able to think logically. And I think a lot of technologists just go in there and hang on for dear life and just try and get through it. You don't have that thought process to be able to logically think about your movements. It's just all, practice makes perfect or something. So most of the good technologists, I would assume you would back me up on this, are technologists that have been in the OR for many years, and possibly near retirement. And the discussions are, what are we going to do once they leave?
I mean, this is sort of a situation in which I think a lot of clinics could find themselves in. And that's why I think it would be really nice to have your Phantom in almost all clinics, especially for us pain practitioners, because when you have someone new that you've just hired, especially if they're just out of school, and like you said, if there's no formal training on manipulating the C-arm such that you can optimize views, that you can use a lingo or terminology in the lexicon of how to describe movements for the C-arm, then it becomes very challenging to perform procedures efficiently, frankly.
Yes.
And so I hope you have that device you patented.
Yeah.
Okay. Good. But yeah, because as far as I'm aware, it should be everywhere. I mean, that in fact, I think should be a part of our training as pain providers, because if you do find yourself in, and I have found myself in as well as my faculty, in situations in which you do have someone fresh out of school for coming from the radiology technologist side, then it becomes very challenging in a case. And I think you and I discussed a case in which I was in the OR and we were doing one of the basivertebral nerve ablation procedures, which, the spine is a very complex, part of our anatomy. And if your starting point for fluoroscopy is not even knowing what, an oblique might be, then it's going to be a very challenging case.
Yeah, and absolutely. Yeah. And one thing of that is for me, the key in my cases was always reproducibility. Because if I'm in, I always hark back to the pelvis cases because that's where I've done most of my work. I could be taking 1,200 exposures in a case.
Yeah.
And my goal is I want every exposure to be useful. That's number one. The second, the ego in me is like, I want every exposure to be perfect.
Yeah.
So when you appreciate the geometry of the situation, it's much, much easier to reproduce. Yeah. Because there shouldn't be, it always used to kind of irk me a little bit when a surgeon would say, come on in and either apply WAG. Oh, it's a 50-50. Like, no, it's not. The first shot is a 50-50, or maybe even an 80-20 because there's some logic in there. Shot two, should be 100%.
And that's good because we're reducing exposure, and then also perfecting the image. And I think that mentality should be a big part of what we strive for. At least it is, it's becoming, I'm a fellow now, I'm in training, but it's becoming for me now to minimize fluoro time so that I reduce radiation for the patient and then also for myself, and then optimize the image, all for efficiency's sake and for safety's sake.
Yeah. So, and that was one of the kind of eyebrow raises that I got talking about this image fulcrum because, from our side of things and the RadTech side, we operate under the ALARA principle.
Yeah, right.
So as low as reasonably achievable. That's all great and well. But coming from a trauma imaging perspective, radiation dose is not the primary concern. I don't even know if it makes the top 5.
Yeah.
Surgical time, case time is really number one. And if I can minimize the number of exposures, and where the image fulcrum concept takes over is if you have a case that requires those many, many images, in the hundreds, although I have more distance between my receptor and the anatomy of interest, my per exposure rate is higher. However, I'm taking significantly less exposures. So when we done a study on this, tentative study, I'd like to try and make it a little bit more formal, but we showed the criteria was we want 10 inlet views and 10 outlet views. And we gauged this with a BB on the receptor and a washer set so that we wanted the BB to be placed directly through the washer. And that would show our accuracy and reproducibility. And we wanted 10 usable, i.e. perfect images. And I compared myself using this fulcrum technique versus a technologist who had been working in pain clinics, primarily on C-arm for over 2 years.
Mm-hmm.
That's a good amount of C-arm usage. Mm-hmm. And we were able to show that the dose saving of myself in the case was 50%. Mm-hmm. And the imaging time, i.e. the time taken to go from one view to the next for the entirety of the 20 was 79% more efficient.
Dang, yeah.
So you had a 16-minute imaging time on the technologist and you had a 3-minute imaging time for me in terms of reproducible images, and there was no wasted exposures. So when you're weighing up, like, yes, I'm more per exposure, but it's a lot less exposures. And that's kind of wrestles with what we were taught from the ALARA. But something you can probably appreciate is the fulcrum, the idea would be is if you're in your PA position or projection and you oblique over 15 degrees, is your technologist holding that anatomy in the center of the screen, or do they find themselves having to boom in or boom back to recenter it?
Right.
So the newer technologists, I guarantee they're having to recenter every single time. So now they're taking 2 and 3 shots to give you that other image. But if you have the fulcrum and you get that intersect point central, and that's where you get in the phantom, is you can go from your PA oblique over, your beam is going through the exact same part, the anatomy, and you come back and you never miss. Yes, you have a little bit more distance. However, you kind of need that distance because your hand is in the field. You need that space to work. So we almost have the fulcrum inherently in the design of the procedure. So it's not, sorry.
Well, so one of the things you're getting at is in having set up your image fulcrum initially. So setting up the very sort of spot, the centered spot you want for your image initially, such that when you make moves, you can reproduce them and then keep the image in the center of the field. Is that of the image rather?
Yeah, 100%. So if you had it set up, then doing it this way, because if you would come in and set up your PA, so now your boom is fixed, right? Because your anatomy is in place. Any movement I make to my boom, my anatomy will drift on the screen, and now I'm imaging a divergent beam. So if I roll over 15 degrees and now see that my anatomy has shifted right on the screen, most technologists will bring the boom arm back to recenter it. However, the more appropriate correction for a fulcrum concept would be raising the height of your receptor, because now your tangential beam is raising up, and now you'll see your anatomy starts to drift back. So when you do it that way, when you come back up to your PA, your anatomy hasn't drifted on the screen.
Interesting. Okay. All right.
So now you can go back over your 15 degrees, straight AP, roll back 15, whatever degree it is. So the only movement that you would have to make going back and forth is your C. You don't have to change your base, your boom, nothing. It's just the C, and that becomes the most efficient and most reproducible form of imaging.
Okay.
That makes sense?
Excellent. Yeah, it makes perfect sense. And that is what the effort of the Phantom is meant to teach, in essence.
Yeah, it's the awareness that if my anatomy drifts to the right on the screen, I am below my fulcrum. If my anatomy drifts to the left on the screen, I am above my fulcrum. So now I don't have to recenter as I go. I can, in my cases, I'm not going to waste 3 or 4 exposures to get it lined up. I will make slight corrections each time I go back. So that within maybe the first 5 to 10 exposures, I now have my fulcrum point, and now I can for me, the case is over, So now I can do the rest of the case with no stress, because all I have to do is, with my pencil marks, hit mark 1, now swing back to mark 2. So I can produce those images within 5 to 8 seconds versus another technologist who's making all these other adjustments, perhaps taking 45 or a minute. When you extrapolate that out over tens and hundreds of images, your case time is now grossly prolonged at the detriment to the patient.
Right. Something that I wanted to discuss as well is the distortion of images when not centered, or I think how we don't really discuss the parallax of images, and we often don't have our image 100% centered, or at least our area of interest 100% centered on an image. Can you speak to how the parallax or distortion affects our images? And then also, for instance, our nail equivalent, like the medullary nails that maybe ortho or neurosurgery place, are needles. And so it's important for us that we talk about a barrel view or a coaxial view or going down the tunnel view. And so it's also important that we know exactly where our needle is within the patient too. And so that's why I think it's really important that we center images as well.
100%. So, I had a surgeon who was very keen on the term of the true beam. He would always say, put that in the true beam. If that's me doing an S1 body on a lateral view, etc. And that just really flipped a switch in my brain that, we study the physics of it, but we never see the implications and the applications when we practice. Because unless I'm working side by side with a precision-based surgeon, I could take 100 x-rays in a day and never hear back from a radiologist, even though my centering may be inches off, because we're looking at more of a gross field of view.
Yeah.
But that one surgeon, Dr. Collins, he always wanted his anatomy within 1.5 inch radius of the center of the screen.
Mm-hmm. Yeah.
So that's kind of where I go. Is my assumption, when you start making all your movements to height, you're always chasing your geometry. So there's no real 100% perfect position, but there's a position that is close enough to capture it, because it's just that one photon in the direct center of the tube to receptor.
Yeah,
that's the only one that's perfect. And
yet our image source is much larger than that. Like the area from our image where I suppose the electrons or the X-ray beams are coming out of is much larger than that. And as such, the scatter, produces reduces the clarity of the image in essence.
Yeah. So if you have your central beam here, then each divergent beam gets further and further out to sweep it. So depending on how far away you are from the center, you're casting a shadow, and you can see that with a flashlight in your hand on the wall. As you move the light, you'll see the shadow move across behind it. So it's that false perspective. So the closer you can get your anatomy of interest to the bullseye on the screen, probably within that 1 inch, if you're really on it, that's really as close to perfect as you can get. Because it's so hard to really appreciate all of the depth, because if you think the principle of a CT scanner is built on an isocenter, so when it goes around that complete circle, every single central ray goes through the exact same point in space. The geometry of a C-arm isn't built that way because it's an oblate spheroid, so it's not a true circle. So there's always an internal drift with the mechanisms of the machine itself. But we're never doing a complete sweep. We're always choosing one point at a time, so that's why the fulcrum is more important from a C-arm perspective. But if you're looking for a down the barrel, then you really want to have a bullseye so that you see a point on the screen.
Yeah. Right.
You don't get any more precise than looking right down the pathway of that central ray. And a lot of technologists, they don't have the confidence to speak up when you have residents or fellows, etc., that don't have the years of experience, or they're also nervous as they're starting out as well.
Sure. Yeah.
So if you see something that looks perfect on the screen and you're not aware of the geometry, but it's over here at the 2 o'clock position, you might be inclined to take it because it looks good.
Yeah.
Whereas the trained technologist can say, let me put that in the center of the screen for you, doctor.
Right.
Yeah. And because of the reputation that the OR has, technologists, I would say 99.8% are afraid to even say anything.
Sure.
Just for the retribution. But I think when you speak up with confidence and you understand your geometry, the surgeons will listen. Because I think that's the reason for a lot of the frustration is the surgeons don't have a lot of confidence in their technologists because they don't demonstrate confidence. And it's not the technologist's fault, it's the industry's fault for a lack of training. Hopefully that's something discussions that we're having here can highlight it and fix things in the future. But it's, another example of that is when you come in and your spine is not truly 12:6.
Yeah.
Most surgeons will say, rotate that image for me a little bit. The confident technologist, the more correct geometric correction would be, let me adjust my base. Because if I come through from my lateral on a rotated screen, I haven't fixed the geometry of the situation. So my lateral will not be truly lateral.
Yeah.
So now the surgeon sees a perfectly lined up image, technologist comes through for a lateral, it looks terrible.
Right.
Surgeon blames the tech.
Yeah.
Which is correct, but for the wrong reason.
Right. Yeah.
It makes sense. And again, it's the justification. Doctor, let me go ahead and fix my base first.
Mm-hmm.
No, rotate the image. That won't fix the geometry, doctor. It'll take me 2 shots max.
Right.
Oh, okay, that makes sense. Go ahead and do that. You know, you need to kind of set your confidence and buy some favor so that you develop that trust with the surgeon, or more importantly, that the surgeon develops trust in you.
Can you speak to some of what the education looks like for radiology technologists? I think most of us in the field of medicine coming from medical school probably don't have a good handle on what that looks like. And I say that because when I did run into a situation in which there was like some, someone fresh out of school, they weren't very familiar with even how to use the buttons on the C-arm. And so, it made me pause. I was thinking, I think I had seen that person in the ORs earlier, throughout the year. And it struck me as strange that they wouldn't know how to collimate, for instance. And even when you discuss, this is another aside, but even when you discuss terminology for collimation, it's like, sometimes I will say iris, or I will say, use like the walls,
the bar. Yeah.
And the bars. Yeah. And like, even for that as an example, people aren't familiar with that terminology. And I just find that strange that there is no industry standard for these things.
Yeah. So the collimation, jumping on that, we'll come to the terminology in a second. It could probably be an entire episode. We may end up having to do this again. It's such a minefield. Collimation. If I can't be precise and put that image in the center of the screen, and I collimate, and all of a sudden you're looking at just soft tissue, where'd my spine go?
Right.
Your next reaction is take that off. Don't bother.
Right. Yeah, exactly. Yeah. Open it back up. Yeah.
So where I was, I could work with 50 different surgeons in a week at Vanderbilt. We had 75 surgery areas doing every case imaginable. And that's a lot of different personalities.
Yeah.
And a lot of different keeping track of, I had a urology doctor who wanted me to collimate to 1 inch using the bar to follow up a stent, urological stent. Whereas I would have others, they wanted full field open because they didn't have the initial trust in me to be able to follow up with a collimated field. So that type of situation, I would have to train the surgeon over a couple of weeks and just ever so gently bring the collimation in, so that when they saw me, they had that trust that, okay, I trust this one. They won't miss the anatomy. So, so in terms of the education, I clearly don't know every X-ray school in the country.
Yeah.
But the general consensus that I have, so I would feel confident talking about the majority, is I think about 60% of X-ray schools own a C-arm. So it's not even a required piece of equipment. I mean, it should be required, but budget-wise, C-arms are expensive.
Yeah.
Again, it's so many tangents in this, so I apologize. But the reality is, for a community college to afford a C-arm, they probably have to buy one that's about 20, 25 years old.
Yeah.
Those controls are no longer in use, so that's one part. So access to modern equipment is a challenge. In terms of the procedures, a lot of faculty may not be comfortable with surgical procedures to be able to speak effectively on how to train them. So most of the training that I hear of students, again, I can only base on the knowledge that I have, and not speaking for all by any means, but a lot of it just comes to, here's how you connect up the viewing station to the C-arm. Here's how you raise the height of the C-arm. Here's how you enter in patient information. They might describe the function of collimation, but I would be fairly confident saying that not very many discuss imaging of procedures, period. Because it's also a little bit challenging in terms of equipment, because if you're on a C-arm lab and you have a class of 20, you have to have individual shielding for every single person in that room. That'll be your state licensure. So at my school, or at South College in Nashville, I do smaller labs where I only have 3 or 4 students at a time. Now, it means I'm teaching the same class 4, 5, 6 times in a quarter, but I don't care because that's my passion. Because I've had the discussion with the surgeons and shared their frustration, and I feel that we're letting the patients down massively.
Yeah.
And this is an environment where the patients don't know.
Mm-hmm.
They're fast asleep. They have no clue. So there's no discussion on how to simulate C-arm cases in a lab scenario, which is such a shame because that's the safest environment to learn.
Yeah.
The only practice that students and technologists get is with a real patient, with a real surgeon, under real anesthesia.
Yeah.
With real stress, every movement. Because when you're moving the C-arm, nothing else happens. Everyone's focused on you until you get the position. They hear a beep, the image doesn't look good. They hear another beep, image still doesn't look good. They hear another beep. So I appreciate the surgeon's frustration, and every beep that doesn't produce an image, the stress goes on the technologist.
Yeah.
And again, the confidence of the technologist. And again, I've done a little bit of this myself starting. I would take a picture, doesn't look great to me, a Lara, I can't just go ahead and expose another one.
Right. Yeah.
But once I got that confidence, it was, okay, I understand that we do not move on until I present the anatomy as needed.
Yeah.
And through time, that got more and more accurate. But again, technologists starting out don't have that confidence, And could you get some surgeons who don't want extra exposures?
Yeah.
But if the anatomy is not good, you have to take another one.
How much background anatomy do you get in radiology technologist school?
So most of the time it's a 2-year school, and most places would do between 3, maybe 4 semesters of anatomy. Spine would probably be, somewhere in the region of 10 weeks worth. So you're talking about all the bony structure, all the facets, pedicles, a lot of the projections, the positioning. But again, it's coming from a flat imaging perspective or a diagnostic imaging perspective. So we don't, we should, but we don't critically analyze every single x-ray that we take because we have an acceptability range.
Yeah.
But that range is essentially 0 when you're in the OR.
Yeah.
So it's a slightly different scenario there. Like if you take a lateral lumbar and the end plates, and at one point in the pathway, they won't be lined up because of your beam divergence. So there's this acceptance of good enough.
Yeah.
Whereas if you're in surgery, the end plates must be perfect. Whichever level you are visualizing in the center of the screen, we need perfect end plates. So technologists, again, they come in, they take a lumbar image, but they don't have that same scrutiny when they're assessing that image. So they always default to the surgeon. And the surgeon's probably thinking, is this tech really happy with that? I get a better lateral.
Yeah.
And there's this kind of back and forth. And I think some of that comes from the ignorance, not a negative term, or the lack of appreciation of what the actual level of schooling is, because it's 2 years to cover the entire skeleton.
Yeah.
Plus the radiation safety, plus the biology, plus, it's a lot. And if there's been no hands-on training of the equipment, which, the experience that you're having with these out-of-school technologists, they're learning on the job, and unfortunately, the ones that have negative, they have a negative context, they don't want to come back into the OR again.
Right. I mean, because most of what we do is an outpatient pain procedure environment, and then we're in like the fluoro suite, as it were. In some ways, I can imagine it being an even more stressful environment if you are coming fresh out. And I have not worked with anyone in that sort of environment who is fresh out of school, because I really don't. I mean, I suppose in residency I did, but they had people to help them. And it would be even more stressful because the patient is awake and they are having to hear, the multiple takes, the multiple movements with the C-arm. But if it moves very smoothly, then it's a very reassuring environment when you're laying face down on a table. And I think that makes a world of difference.
Absolutely. And it's the same scenario. Those technologists, they only get that practice in real time.
Yeah.
So coming back to the phantom idea, hopefully there's enough angulations within the phantom that we can reproduce. And it's not all inclusive. They're very generalistic, but it's the appreciation of, I can find a position to go back and forth with not minimal movement. So it's a little bit of that the phantom is designed on. I done pain. I was fortunate when I was a student, I was at a location that they used to do their pain cases in surgery. And a lot of the technologists didn't like the doctor.
Yeah.
They saw that I liked the C-arm, so they kind of pushed me into his cases, and I just enjoyed it. So I got a lot of practice with that. Again, a lot of the views escape me now. If I had to go back, but I would pick it up.
Yeah.
But even with the technologists, in terms of schooling, I don't even feel that we have to understand the procedures.
Mm-hmm. Yeah.
It's more important that we understand the geometry and the manipulation of the equipment.
Yeah, absolutely.
Because if a technologist comes up to you and goes, I haven't done one of these cases before, but you tell me what you need, I'll give you 100% of the time.
Right.
You will be a little bit more forgiving in terms of those first couple of exposures, and then exposures 4, 5, and 6 are perfect every time.
Yeah.
But if you have a technologist who just keeps that information to themselves, your assumption is, okay, they know what they're doing. And then you get frustrated quicker because the technologist is now flapping. They don't know to move the right way, or they don't know which correction to make. They feel the eyes burning on them. They start getting more stressed, and it just compounds itself.
Absolutely. It kind of defeats in some ways what we're talking about here. But the technology of C-arms, I think, could be improved. And I haven't worked with like a brand spanking new one that I know of, but there could be a feature in which you could save angles and distances on the boom, and then the height. You could save position, and then if you move it, you have that. Maybe it has a memory for 1 or 2 positions you saved temporarily. You could do switch save position, and then it automatically readjusts. Or the metrics, the parameters of where the boom is or how high the C-arm is, could be digitalized such that you can, because you have to look, you have to look on the C-arm where the angles are. And, it's not a big stress, but if you digitalize those, you could memorize them much easier.
So the newer C-arms have that capability,
really,
especially the ones that are more so the ones that are 3-dimensional capable.
Wow. What's that?
Zeem has one. OEC all the big players have one.
Yeah.
But your level 1 trauma facilities will probably get that first because they're $500,000.
Right. Oh, wow.
Probably up, the 350 hertz. And pain management is not going to get those types of C-arms.
No, they're not. Yeah, exactly.
And orthopedic surgeons don't really like them.
Yeah.
Spine enjoys them because they can pair them up with the navigation software. But one thing, so those automated C-arms, I feel as though I need to express caution on those, because a trained technologist will always be faster.
Yeah.
And more understanding of the environment. If something changes, you can make that adjustment in real time. Because from a liability perspective, these machines cannot exceed a certain pace, because they don't want to hit anything that's inside the patient. So if someone's not paying attention, and now you have a guide wire sticking out and the C-arm just keeps, how sensitive is the buffer on it? So I would definitely express caution on those, and I would put more investment into training the staff, the technologists, because it's also that human interaction.
Yeah.
You know, it's already lonely enough as a surgeon
Yeah.
without having to take care of all the imaging as well.
Right.
And I will also say that this is where engineers don't understand the need of the machines. So now we have C-arms that are operated via touchscreen.
Mm-hmm.
So if you want to oblique over, you would drag your finger up the touchscreen.
Oh.
Well, if you have any anatomy software on your iPad,
yeah,
that moves and jiggles as you can't keep a straight line. So again, not paying attention, I might apply 2 degrees of angulation.
Yeah.
Now we're talking about beam divergence.
Right.
Now we're talking about the anatomy shift. Some of the newer controls, the locks don't hold when you're going through these complex cases. You know, so yes, they might be easier to operate, but now they're much harder to be accurate.
Yeah.
You know, so the older machines like your 9900 that I used to use pretty much all the time at Vanderbilt, they were hard, aggressive locks, but you put that in place, that was not moving.
Yeah.
You know, it held. Whereas now, they're a lot more sensitive, a lot easier to move, but because of the brake mechanism, they don't hold their position anywhere near as long. And using the inlet outlet, the speed that I would move, maybe 3 seconds from an inlet to an outlet, moving at that speed now puts stress on, you know how the OECs have that, the never lever, the piece of the equipment that's like, oh, we don't touch that part at the bottom of the L arm.
I haven't seen that.
So there's a lock on the C arm. I personally think it's the most valuable lock on the C arm, but every technologist is told, don't touch that one.
Which lever is that?
So that would be your flip flop. If you were wanting to get the L arm raised up over top, that's how you would do it on an OEC. It's the lock that sits at the most bottom part of your C arm.
I see. Okay. If you wanted to rainbow it over the top of the patient, is that the
yes. Yes.
Okay.
So you just two. So your L arm on an OEC is the long arm that comes down. It looks like the mirror. So you because the lock I'm talking about doesn't reverse the receptor in the tube.
Okay, got it.
You know, you can use your tilt function to bring your receptor underneath.
Yeah.
And go over. But the proper way to do that would be using the L arm. But now if I'm moving fast between inlet and outlet, that smart scan lock loosens off.
Mm-hmm.
And if I'm not aware of it, it angles quickly. It's the equatorial mount. So I could apply 15 degrees off my tilt axis and not even realize it. You know, so I'm not a huge fan of the newer systems because I think they've been engineered worse for precision.
Yeah.
I mean, image quality, incredibly so much better.
Yeah, really.
You can't argue with it, but they're definitely a lot more delicate and they're not built for true proficiency. And it's a shame, you know?
Yeah.
Can we get the old locks put back on these new ones?
Yeah, that would be really nice. Right.
You know,
I think, you touched on some things that are really important. I think the whole team member aspect of a technologist, and, in your case, it's often a surgeon. In my case, it'll be a proceduralist. I think those things they're a really important part of being in these environments in which you need to do, in your case, probably more high stakes procedures. But in our case as well, it's nice to have a team member you can rely on. So I think that's a big part of it. I would be remiss, Ryan, if I didn't ask you as well, what the key movements, what the major movements are of a C-arm. I think it would be nice to hear from you what you call those and what they are.
Okay. And again, I am not speaking from an industry standard because there is none. With the common. So you had a great video on it, and I probably shared about 90% of the terminology. So there are 6 degrees of motion. So, because as soon as I heard you say that, I was like, this man knows. He must. So let's see if we can go through it from our head. So we have the height. So you would raise and lower.
Yeah.
And then you would have your boom, which is your in and out. That's the one that probably gets a lot of names. Plunge, telescope. I think there was a couple of other comments on your LinkedIn about that.
Listening as well. Yeah.
Yeah. So boom in or out is usually the preferred for me.
Okay.
Then where it starts to get a little bit different is you would maybe reference it to oblique.
Yeah.
Whereas I would look at it as C or roll, or C roll over. Because if I'm doing spine, of that movement, the oblique makes perfect sense. But if I'm coming in for an odontoid screw, or I'm coming in for a clavicle where I'm coming in over the patient's shoulder, my oblique is now operated by my tilt. So I don't want to apply a terminology to a movement that in a different situation no longer makes sense. Because that's just one other little window of confusion. So that way the C roll over, roll back would just be, I need the C function regardless of what axis or plane you're imaging.
Okay.
And then we have the tilt function. We typically don't reference caudal or cephalic. We would usually just say tilt to the head, tilt to the feet. Same deal, but that caudal and cephalic trips people up because is the patient prone? Is the patient supine? Is the tube coming from PA to AP, or is it AP to PA? So that just, when the patient's all draped and you're coming in to shoot a quick picture, they'll say, go ahead and inlet tilt for me. And you come in and go, well, that's an outlet. Is this patient prone? Is this patient supine? So the tilt would be correct, but usually in terms of the receptor, tilt to the head would be the receptor moving towards the head.
Okay.
And the same with the feet. And then we have slide, which would be the entire base, north or south. Again, the description would always be slide north for me, slide south for me. And then the wag, the wig-wag function. That's the one that, if I could remove any lock from any C-arm, that would be the one. Because talking about geometry, it's very detrimental because if you're lucky enough to have a calibrated wag, that's okay. But you can apply wag and then forget that the wag is on, because the wag actually draws the circumference of a circle. So the wag arcs the anatomy. Because if you were shooting an AP and you apply wag, you would see your spine turn.
Yeah.
When you're using wag, because the central ray is moving away from the path. So it would actually turn to the other way. So that's why I don't really like the wag function. The only time I would ever use wag is if I'm doing a femur and I have to shoot a perfect knee joint, because the perfect knee joint is not the same plane as a perfect lateral for the femur. So we always want to be perpendicular to the anatomy of interest. But just for that image of the knee, it's easier to put on a quick wag correction and keep my base perpendicular or parallel with the femur. So that when I take my wag off, I haven't lost my true central ray path for the rest of the procedure. So that's about the only time that I really apply wag when I'm looking at precision. If I'm doing something like a portacath or filter placement, bronchoscopy, you're just looking for bird's eye coverage. So the level of precision is not in those types of cases. So wag away. But if anything, sorry.
What about trying to set up a true lateral for the cervical spine or the lumbar spine? Is that ever really come into play for you using the wag, or do you like to just change the base of the C-arm?
I would always change my base because I want to work under the assumption that I will be taking more images later. If it's, because that's how I'm going to fix it. Because if my goal is to wag the C that way, well, I could do it with the wag, but now as I slide north, my beam will drive away from the, or it will drive across. So to keep the geometry true, I want to keep my the boom completely 90 degrees from the base wheels, so that I can follow up that way.
Yeah. Okay. Excellent.
That makes sense.
Yeah.
If you had a tricky case where you had a patient with a lot of scoliosis, most surgeons will say, come in and shoot a lateral, show me a lateral first, or shoot the scout. If I can validate for an extra exposure, I would always request an AP on the way in, because right there, I can see all those deviations and I can make those corrections before I take my lateral.
Okay.
So I don't have to correct and line it up on that AP. If my AP is a little bit off, then, okay, I didn't come in perpendicular. Let me swing through for my lateral. Let me apply the correction to my base. So now I can guess or logically correct without having to take those extra exposures. Because, if I do a lateral and then apply a Y correction, my first exposure is not useful. But at least if I come in and take an AP PA, yes, it might not be perfectly aligned, but it is still a useful image because it shows me the anatomy in that projection. So I can now base my next move off of that. For you, you have your AP on your reference screen and you have your lateral that now we're working with.
And just a clarification for terminology here as well. Our image source shoots a beam through the body, being the interior portion of it, and then receives either cervical or the image intensifier in the posterior portion of the body. So we call that an AP image. We don't really ever take PA images. Is that the situation? Or in this situation, because you're using a C-arm, does it really matter what we talk about? PA versus AP?
So, and this raises a really interesting point, because for me, I always want my thought process based on the central ray.
Right.
So if I'm using central ray, I don't really need to consider beam divergence because there is none.
Yeah.
However, what I do consider now is magnification, because now the distance from the source is magnified greater. So in your case doing pain, most of your patients would be prone position.
Yeah.
So therefore, your tube entrance is closest to the anterior portion.
Right.
So it is impactful because if you have, let's say you're in a situation where it's a pregnant patient, you want to know where that source is closest to the anatomy. So that would be one where, let's say it's trauma and an acetabulum or pelvis on a pregnant patient. I'm not going to use, for my skill, I'm not going to use the fulcrum idea because I do need the dose reduction of every exposure.
Right.
So I would keep my receptor there. Again, there may be a balance of a time issue, but again, with the experience, I can work quicker and not observe the fulcrum idea because the case needs that change.
Yeah.
So in terms of the technologist, it is important to understand where the beam emanates from.
Yeah.
Because if you're trying to make a correction on a divergent area of the image, you have to know which way that beam is directed so that you can make those adjustments. But if you always base your corrections off of the central ray, divergence isn't an issue.
Right. That's a very valid, good point to keep in mind. I think, and, I want to be mindful of your time here because, we're about to hit an hour, but, when it comes to even talking about sort of the physics of using fluoroscopy, we don't really keep in mind, I think, enough where our receptor or the image intensifier is so we can reduce magnification, improve clarity of the image, and then also leave room to use your hands on top of the patient. And that's not something I feel like we discuss enough, frankly. And using the image fulcrum as an idea kind of obviate that. Like, you don't need to really talk about where the image intensifier is anymore because it would kind of be in a permanent place regardless of where you are rolling over the patient or not.
Yeah, and where it really gets challenging is obesity.
Yeah.
Obesity is
Yep.
probably the most complex addition to any procedure,
Yeah.
in medical imaging, because there comes a point where the limitations of your machine in terms of the adipose tissue and the amount of scatter generation, you just can't really overcome that effectively. Giving you a case in point, when we used to do localizing images, surgeon would place the needle in the L4 joint space, let's say, and you would come in. If you had an obese patient where you have a lot of adipose tissue on the flanks, you can't see your needle. You're completely burnt out because you're trying to penetrate the anatomy.
Right.
So it's one of these where you can find a balance point of just going through enough skeletal anatomy that the ABC, or the automatic brightness control, is being gauged by the soft tissue.
Yeah.
So there's a little bit of a balance point in there where you can still see the needle, but you can still see the skeleton. Or do you have trust that, okay, I'm going to take 2 exposures. I have to blast through my L5S1, and then I raise up 4 inches so that I can see the needle, and then superimpose those 2 in your head. Sometimes you can't get them all on one. But again, it's having confidence in a technologist that knows to only change the one thing, So it's just some of that comes with experience, but I want to take away a lot of that time it takes to learn it.
Yeah.
And bring that into the OR within the first 3 months of employment.
Absolutely.
So
I'll ask. Oh, go ahead.
I was going to say, I know we won't, but I really could talk all day about this. Jumping back on the education piece real quick, is the requirement from a radiology technologist to be perceived as competent, as entry level, is 2 C-arm procedures. One is a single view around a sterile field. And the second is any C-arm procedure that requires 2 views, typically an AP and a lateral.
Yeah.
Doesn't need to be sterile or not. To me, the whole sterility thing, I shouldn't be hitting anything with a C-arm anyway, so I don't even think that's a valid point. But yourself, there's a lot of variation in what cases use an AP and a lateral.
Yeah.
So if you're hired on as being a competent tech, and this was a challenge that I faced myself, is I was doing all the complex cases. I had a weekday day shift, so I had the lowest rate of pay. I was the least experienced on the team, so I had the least rate of pay. And when I brought this up to my manager, saying, how can I accelerate my earnings because I'm meeting expectations, that good old phrase. And I was met with it's an entry-level position, or it's just an entry-level task, and it's paid accordingly. And as soon as I heard that, I knew my manager had no clue the demands that are placed on C-arm technologists.
Absolutely. Yeah.
So my ultimate goal would be to have some form of advanced certification within radiography, where a technologist, can start out as entry level, but there's a qualification out there that now kind of sets them apart, knowledge-wise, geometric awareness of C-arm, maybe a 6 months program that is added in, so that now, as a career path, and I don't know how long you've been in the OR field, but it must be one of the most frustrating things for a surgeon to have great trust in their technologist, only to lose them to the cath lab for an extra $5 an hour, or lose them to MRI or something, because all the time that's been invested in training them.
Right.
Ultimately, money is, I love my time in there, but I wasn't stupid. A point where I had to make a decision. But I knew, and I didn't want to go into any other modality.
Yeah.
So the way the world of radiology works, they almost kind of force you into another modality, all of which those modalities make radiology more money than surgery. because the way reimbursement works, the radiology department doesn't make any money off the back of the rad techs that are working in the OR. The OR gets that, So I don't think C-arm technologists dedicated C-arm technologists should be housed within the cost center of radiology.
Well, it's strange. I mean, OR time is some of the most expensive time on earth. And so if you can potentially make that time more efficient, then you will benefit not only the technologists in helping pay them more, but the hospital system in general. And so I think that is definitely a case to be made for that. I'm not a surgeon and I don't work in the cath lab nor an IR suite, but I have worked in ORs and doing, mini surgical I wouldn't say necessarily sometimes surgical procedures, sometimes not. But I think there's a big case to be made about the efficiency and the expertise for technologists there. And I think they play a huge role in that. So it's an unfortunate reality, I think you're pointing out.
Yeah. And it's really, the argument changes depending on your audience, because for certain leadership, it all comes down to money. So if you can entice them with quicker case times, quicker turnarounds, if you're in a trauma center, then getting that extra case done that day. Yeah. I don't know any surgeons that would ever turn down cases, but when they run out of hours in the day, there's no way for them to put them. But if you have a technologist who can image 80% faster, that downstream impact means less overtime for staff.
Yeah.
It also means that there's the potential for getting that extra patient in rather than holding them off till tomorrow, or even worse, holding them off over the weekend until the good techs are in on a Monday.
Yeah.
The two challenges that I heard when I was reviewing my talk was trauma surgeons talking about institutions that are hiring a lot of travel techs. And they're, institutions are hiring almost exclusively on the demonstration of OR experience.
Really? Okay.
Because we can't get anyone to go to the OR because everyone's petrified. Yeah. So if I can force a travel tech into that environment who says they're OR comfortable, that's where they get placed. I personally found it a point of embarrassment that you would have travel techs come in to a dedicated level 1 trauma center and take over the cases. No. It's like, this is our job. But the surgeons, they felt that an advanced certification or credentialing would give much greater confidence because now they knew the quality of the tech that they were getting.
Yeah.
Because OR experience does not correlate to quality.
Yeah.
And it doesn't equate to precision and skill. But from the technologist point of view, if that credential can also come with a significant pay bump, if that had happened to me and that was there, I would probably still be in the OR doing those cases because that's what I loved. Again, I was shown the door of every other modality that paid significantly higher. Yeah. I had no interest in it.
Yeah.
All the surgeons would speak up for me, but radiology was the one that paid me.
Yeah, right.
So they're not going to let you jump the experience queue on pay just because X, Y, and Z. So the payment structure doesn't really support that either,
Yeah.
So it's a tough one, but I definitely think it's something that needs to be looked at because we lose too many good technologists and great technologists just for really a few dollars an hour. And when you look at the cost of reimbursement or how much the department, the OR makes per case, an extra $10, $15 an hour for a C-arm tech is pennies compared to the reduction in costs or the increase in revenue.
Right. Yeah, no, I completely agree. I mean, we're all part of a team in an OR, and I think raising our standards as much as possible will make a big difference in the efficiency and, I mean, subsequently, the revenue for the hospital. So I think there's a big case to be made for that. I think you'll get there. And I mean, so what would this certification be? What would the name of it be?
Well, my initial discussions were really kind of thinking of it as, something as straightforward as an advanced practice radiographer.
Okay. Yeah.
Or because C-arm imaging is not looked at as an advanced modality, but in terms of the in the moment skill, and you're in a case with a surgeon who should trust you, and you said the word, a team. You're part of a team in that OR. Those orthopedic surgeons look at, and this comes from their words, from their mouths, they view the C-arm imaging as the most advanced imaging skill that there is.
Right.
And it's beyond their belief that it doesn't get the pay that supports the skill and the reliance of the team on that tech to show up and do their job to the best of their capabilities.
Yeah.
So, you need to be cautious about making it an advanced practice radiographer. But you could maybe be an APR1, APR2, where one could be a trauma specialist and two could be a surgical imaging specialist. So I think it's more likely to be an offshoot of that rather than be a C-arm tech, because that's very narrow. Plus technologies are changing so much that the expectation of surgical imagers now, you have your portables in the OR as well, but now with the advance of 3D imaging, you're essentially running CT scanners. They're technically not classed as CT scanners, but it's almost CT technology. I'm talking about the fulcrum idea. That is what they run on. You have to be centered in your AP and lateral planes so that you get that isocentric sweep.
Yeah.
So all of this is now the demands on the C-arm technologist, but there's no education to actually make them aware and allow them to invest in themselves to maintain their skill, Because if the experienced techs don't keep up with the newer technologies, they become dinosaur real quick. And that's an unfortunate consequence of leadership, is that's where they look to trim fat and everything. So it's try and make yourself indispensable and invaluable to the right people. So I think that advanced certification, they would also have probably a CE requirement attached to it as well, similar to mammography or radiologist assistant, where a certain number of your CEs have to be modality specific. Would also be a second part of that as well.
Well, I think this is kind of an inspiring note to end it on. I'm looking forward to the future, and maybe we can continue having these conversations too, because it's really interesting.
Absolutely. Thanks so much for the opportunity. You're doing a fantastic job of your videos out there as well. So I always, the ASRT, they have this Be Seen campaign. And it's a great campaign because people don't really realize what rad techs do.
Yeah.
But my one caveat to that is there's a glass ceiling there when you're advocating for yourself. But when the radiology technologists can have people such as yourself who have a much stronger voice in the industry advocate on our behalf, I think that makes a huge, huge difference. So that's the second part of my, wish, is to bring people like yourself to the table so that we can be heard all as well as be seen, because you see us and they don't hear us.
Yeah, absolutely. No, I mean, radiology technologists are an absolutely indispensable part of what any of us do when it involves imaging. And you can feel that most apparently when you don't have one, or someone that doesn't really know what they're doing, no fault of their own, but because they don't have experience. And like you had kind of said, is that the education part is not there yet. But I mean, it's really inspiring that you're filling that gap. And I think, we're obviously, getting to the point where we can see there is a gap there. So
yeah, it's being seen. We're starting to pull it apart and get it be observed. So I think the right people are listening, are very close to listening. So hopefully this is one further step in that pathway.
I think it is. Well, thanks again, Ryan. I appreciate it.
Thank you so much, Derek.
All right.
I'll talk to you soon.
Talk to you.
Bye-bye.